My name is Krishna Nirmal. I'm a neurosurgeon in practice at Natick, Massachusetts. I did my neurosurgery training at the Massachusetts General Hospital in Boston and my medical school training at McGill University in Montreal. I'm going to be talking today about artificial cervical disc replacement surgery in patients where it is indicated. So these are patients who have tried conservative management for symptoms of neck pain, arm pain, weakness, numbness, and they've had a study done with an MRI scan or a CAT scan with myelogram, which shows that there is evidence for pressure on the nerve root or the spinal cord, either due to disc or bony changes that requires surgery. So there are two kinds of basic operations that one can do. One is the spinal fusion surgery, which has been done for many years, and it's a perfectly good operation. What I'm going to be focusing on is the artificial cervical disc replacement surgery, which is to preserve motion of the cervical spine, and it can be done for 1 or 2 levels. The typical patient for this would be someone who does not have severe arthritis or rheumatoid arthritis, who does not have an infection, has clear indication in terms of disc or bony compression, and who does not have osteoporosis. The disc replacement surgery can be done for 1 level or 2 level cervical discs with this disease. The basic operation is done with the cervical spine, where the operation is done from the front of the neck, where the disc, which is herniated, is removed. As you can see on this model, it's this pink material, which is the disc herniation that's compressing the nerve or the spinal cord. The outside of the disc is maintained. That's the same operation for a fusion or for the disc replacement. For the disc replacement surgery, there is motion preservation, meaning the artificial disc, which you see here, preserves motion in terms of bending forward and backward, going forwards, which is called translational motion, side to side bending, and also allows for some twisting. This is to preserve motion so that there is less chance of developing arthritis at the segment above and or below, and also so that there is much quicker return back to work by the patient with less pain. The results of this disc have now been monitored and followed for 5 years, and it shows a clear superiority to using the artificial cervical disc in terms of pain, in terms of adjacent segment disease, and having repeat operations compared to doing a spinal fusion surgery.